All right, good morning, everyone. Let's go ahead and get started in the interest of time because people are going to have to leave around 7:45, 7:50 to get to the operating room. It's my pleasure to welcome the OR staff. To my knowledge, and I've been here a long time, this is the first time that we've ever actually had a joint grand rounds between the operating room staff and the Department of Surgery. And this morning's topic is one that is very important to both of us in OR fire safety. I have the unfortunate responsibility to tell you that we had an OR fire on Friday night. The argon beam handpiece caught on fire. There was no injury to the patient. There was no problem with the staffing in the room. And so the response to that event was the appropriate, safe one. But this is a current day problem that we all have responsibility. And I have the privilege of introducing to you Dr. Eddie Jones, who's a professor of surgery in the GI Trauma and Endocrine Division at the University of Colorado, but he also is the chief of surgery at the Eastern VA Health System. His background is that he started his education, higher education at Harvard University, where he got his undergraduate degree and graduated in 2005. So we can now count him in the ranks of all the old guys. He got his MD at Case Western Reserve, and then he did his residency here at the University of Colorado and finished in 2014. He then went to the Ohio State University, where he did a fellowship in endoscopy, and one of his roles at the VA is he's the director of surgical endoscopy as well as nutrition. He also is a lieutenant colonel in the 629th Forward Surgical Team in the U.S. Army Reserves. And since 2017, he's had 3 deployments. So we should thank him for his service to our country. He's had a very and he still works with the military, obviously, in his role within the VA system. He's had a very productive academic career. He's published 83 manuscripts and 12 book chapters. He has 7 extramural funded grants. And in this particular topic, he's the co-chair of the Society of American Gastrointestinal Endoscopic Surgeons Committee on the fundamental use of surgical energy. Thanks, Dr. Jones, for doing this grand rounds.
How's this? Nothing? How about now? I don't know if I can get much closer. Is that working?
Yes.
Okay. All right. Well, thank you so much, Dr. McIntyre, Dr. Schulich, and all of the OR staff for coming today. This is an incredibly important topic, and it's one that I know a fair amount about. I've been lecturing on this as part of SAGE's, Society for American Gastrointestinal Endoscopy, or Society of American Gastrointestinal Endoscopic Surgeons, I'm sorry. And it's the FASGE committee, Fundamental Use of Surgical Energy, which we'll get into a little bit later on. But it's really the only certifying exam available out there for anyone who wants to know more about the safe use of energy. And we are one of the first, and as far as I know, only programs led by Tom Robinson, who was one of the co-chairs of FASGE a few years ago, who pay for all of our interns here to get FASGE certified. And I'm not sure that that's offered anywhere else to any other programs. And so our residents here know more about surgical energy than some of the attendings in reality, because they have done this training and they have thought about this. So today, let's focus on OR fires. We'll discuss what exactly is an OR fire. And then we'll go on to the incidents, talk about what we can do to prevent it, what happens if there's a fire in my OR, and then look into some guidelines that recently came out to help emphasize where we should go from here. So everyone wants to imagine the beautiful campfire, marshmallows and whatnot. In the operating room, however, that's not what happens. There's not this big thing and people are raising their hands and screaming. Instead, it's typically an alcohol-based fire, which has a beautiful and very hard to see blue flame, especially when it's encircled by blue drapes. Not only that, but the official definition from the Joint Commission is something like this: a rapid oxidation process with a chemical reaction, or a smoldering condition without a flame. What does that bring to mind? Light cords, right? Leave that on the drape. Not only can you burn a hole through the drape, but you can burn the patient. And this has been described a number of times. So we've done a little bit of testing. I was fortunate to go to India as part of the FASGE program and teach FASGE to them. And they let us do some pretty exciting things, including lighting fires, which I'll show you a little bit later on. But I just want to emphasize that light cords, this is in a controlled setting, can light a fire too. So we need to make sure we are constantly thinking about preventing a fire. How common are they? Fortunately, not that common if you think about how many procedures are done, and we don't have great data because no one wants to report an OR fire, especially if there was minimal or no patient harm. The best data we have is back from 2009, a database review in Pennsylvania, which reports or would average throughout the US about 500 to 650 events per year with 2 to 3 deaths. Okay, that's not too bad. What about now? This is a study I did with Dr. Robinson, Doug Overby, who's now doing CT surgery out on the East Coast, and we looked at the MOD database. So there's an FDA database, manufacturer and user device experience. Anytime a device breaks, you're supposed to voluntarily go in and report it. This data is free. You could Google it right now. And what we found when we looked at surgical fires is there's an increasing incidence reported on this voluntary database. 30, 40 a year, and we can all assume, I think very confidently, that this is underreported. What other data do we have? As part of the VA tracks all critical incidents. So similar to a sentinel event, in the VA it's called a kitten, and burns or fires are included as part of that. So I did a recent review at the National Surgery Office, and you can see the trends there. So not only did we have burns, which were mostly the light cord related burns, but we also had real fires, and this is throughout the entire VA. And again, these are only the ones that are reported. Now, you're supposed to report it, but if you lean on the bovie and the skin is just a little charred and you don't report it, then maybe it's not in here. And so again, I think we are underreporting events. So over the last 2 years, there are 38 events reported throughout all of the VAs, and patient injury happened in at least half of them, although 7 of those we don't know. The vast majority of the time, it was our monopolar energy device. And this will be something that will echo throughout the rest of the presentation. Light cords and lasers are our other big ignition sources. Let's look at the Joint Commission. They report their sentinel events, and we can see about halfway down there, they reported 58 burns in 1 calendar year, fires or burns. So this is still happening in RORs every year. How do we prevent these things? We got to think about how a fire starts. And there are 3 critical ingredients or 3 pieces to the fire triangle. There's a fuel, which you can see alcoholic-based skin prep is far and away our most common. We'll go into that in more detail, but the drapes, gowns, even the patient's own skin, hair, tissue can be the fuel. We need an ignition source, a heat source, which is most commonly the bovie in about 90% of reported cases, but can be lasers and fiber optic light cords and other things that get hot. And then we need an oxidizer, which is most commonly oxygen, but can also be nitrous oxide. The other thing that complicates this is that it's not one person's deal. In the operating room, it's a team sport. And with fires, it is even more critically a team sport. Oftentimes, the prep is done by the nurse. Maybe it's done by the surgeon. Could be done by the tech. Maybe different in each case, different in each situation. Maybe we're doing this in an outpatient center where we haven't done any fire training. And there's just a little mole right up on their face. They're just going to do a little local prep, and it gets into the hair and it's still wet. There have been a number of reports of fires in those situations. Anesthesia is going to manage most of our oxygen content. And then the surgeon typically is utilizing the energy source. But at other times, there may be other things that have lit on fire. and that's a little bit outside of the spectrum of this, but if you look in the MAW database, you'll also see reports of device failures that may happen off the field. You'll see smoke evacuators that are broken and lit on fire, and those things are typically managed in a far different way. But we're gonna focus on, in the operating field, what can we do as surgeons, nurses, and techs to prevent fires? Let's start with what I would argue is the most important piece of the triangle to think about. And unfortunately, it's usually dealt with by anesthesia, but we need to bring this all together and make sure we're all part of the fire discussion. So closed came analysis looked at the prior decade worth of surgical fire cases that were settled. They found that 85% of these cases occurred in the head and neck region, near the airway, and 81% were monitored anesthesia care. I think this makes a lot of sense, right? Oxygen that is not controlled through an endotracheal tube or an LMA is going to leak out onto the field. And even in a low flow system, 4 liters of oxygen or less, we're still increasing the local oxygen concentration by 5% or more. You dial that up to 5 liters, and on a lot of the little monitors, I don't know if you've ever looked at the oxygen with the little ball in there. It kind of like goes 1, 2, 3, 4, 5, and then there's like a gap 10, and then a gap like 15. So it's very easy to kind of dial it up. You drill it up to 5, and all of a sudden we got a local oxygen concentration of 35 to 50%. You do something crazy like this drape, I don't know where, I found that on the internet, I don't know what was happening, but you do something like that, that's a recipe for disaster. What we found is that an oxygen content, local oxygen content greater than 30% creates fuels. How do we know this? And this is just 4 or 5 liters supplemental oxygen. Beautiful study out of Texas by Bill Culp and his team looked at common sponges, drapes, gowns. Some of these were marked as non-flammable. Some of these were marked as class 1, normal flammability. What happens when we change the oxygen content? Well, let's take some things that did not ignite, drape and a gown. We turn up that oxygen to about 7 liters. Now we have a local oxygen concentration of 50%. That light's on fire, 0.2 seconds, 0.4 seconds. This is a non-flammable item. We turn up the oxygen, everything's lighting on fire. Oxygen is critically important. As you turn it up, things burn faster. Sorry, that red box is a little off, but you have a burn time in room air oxygen, 21% of 21 seconds. We turn that oxygen up, we give them 6 liters nasal cannula, it burns in a third of that time. And when a surgical fire happens, it takes 1 second, 2 seconds, and you pat it out. It's very quick. In that period of time, critical injuries happen. And we'll go into a little bit of the medical legal aspects of it as well. I think this graph really sums it up from his paper, and it's the idea is as we turn the oxygen content up, we see decreasing burn times for things that were not even flammable in the beginning. This is just how critical the local oxygen concentration is. So what's the big deal? This fire occurred, according to the documents, it only took about a second, maybe a second and a half before they put it out. Monitored anesthesia, little mole on the side of the face, should be a quick case, easy in and out. What happened to this? It went right to the press. This was another article that was forwarded just yesterday by Dr. Meacham. Hospital patient catches on fire. If you read the article, they're getting sued for $900,000. These are happening all the time. And one of the other problems with it is you go to settle. And our practice shouldn't be defensive medicine. That's not what I'm saying. But I'm saying when a surgical fire happens, this is based on multiple Supreme Court filings. Basically, you're negligent. There's no way, and it's not just surgeons. I've been on cases with cardiologists, replacing a pacemaker, just doing a little pocket, just flipping it out, lit on fire. Neurosurgery, interventional radiology, GI. Fortunately, not GI anymore because we've changed our prep solutions. But you can't defend it. So how do we treat this? We have to prevent it. All right. So the press, while we like to dislike them, especially at the VA, they seem to only publish negative articles about us, they can be very beneficial. So this is a nice review I did with Soam Roy. He's the chief of ENT and probably one of the world's best fire experts, who's just across the street, which is amazing. A review I did with him and some partners out of Wright State, and we looked at fires again in the MOD database, only those that caused injury, and we found that there was this weird kind of drop-off or downtrend that started in about 2012. And if you just do a Google search, granted I did use ChatGPT and a little AI to help me, you'll find publications coming out. Anesthesia Patient Safety Newsletter came out right in that time frame. Not only that, they were making videos. And one thing I would encourage everybody to do is just Google APSF surgical fire video. There are 2 videos on their websites. One's 5 minutes, mostly targeted at anesthesia. One's 18 minutes, which is everybody. And that is one of the most horrifying pictures, which I should have pasted in here, of flames just blowing out of the end of an endotracheal tube, emphasizing just how critically important it is to think about this. We see multiple publications during this time. And then what about 2017? This is really when we see it drop. Well, this is that unfortunate story I just mentioned. Good Morning America, this simple procedure which resulted in this fire. Fortunately, we were both in front of it and aggressively supporting it. Multiple surgical societies now publishing a number of things. This is one of the best websites that I found, ECRI Institute. They were the ones who published that 2009 data that I showed earlier. And they actually offer surgical consultations. So when you have a fire event, they will fly in for, I'm sure, a nice fee, and they will do training and try to get everyone on the same page with fires. There are a number of things mentioned in here that are worth looking into, but in the interest of time, we'll kind of keep moving on. So back to the oxidizer. We need to use the lowest and safest oxygen content. If it's a high-risk situation, you're going to be using a lot of energy because there's a lot of bleeding in the head and neck region or anything above the xiphoid. Please consider a closed system, such as an endotracheal tube. It's not perfect, right? If the balloon fails, you're going to be leaking oxygen in there. So we still need to be constantly talking with our anesthesia colleagues. Think about a tracheostomy. Before you make that incision, if you're going to use energy, which is not always the best choice, but if you are, just say, hey, anesthesia, I'm going in the airway, turn down the oxygen. You wait 60 seconds, get them down to room air, should be okay. Avoid creating pockets with your drapes, and then remember, ultimately, cold steel is not flammable. So if we need to make an incision, sometimes the knife is the best. Okay. Moving on, energy sources. I won't spend too much time on this because I think it's relatively straightforward. But as I already mentioned, 90% of surgical fires are begun or ignited with the handheld Bovie, monopolar energy. And this is not at all surprising. We have all, I think, or at least all the general surgeons, but most everybody here has intentionally created a spark gap to get that energy to splay out and create a nice superficial burn. You do in the gallbladder fossa when you have some oozing and you don't want to get into depth. But in laparoscopy, that's a safe situation. The abdomen is filled with carbon dioxide, which is a fire suppressant. In the open air, if you have a pool of alcohol, that is not a safe situation. So we have to be constantly aware. Lasers and light cords are other sources, as I've mentioned. And so this is pretty straightforward, I think. If we're in a high-risk situation, we're doing a trach, or we're getting into the airway, or working in the mouth, we can't turn down the oxygen because of patient disease, we get into bleeding, we cannot be reaching for a high-risk device. Even a bipolar device would be better than something that creates a spark gap. Argon, handheld monopolar. Or let's use good surgical technique and stop the bleeding with a suture. All right, lastly, focusing on fuel sources. And I left this for last because I think this is another area we can make a big impact, especially with our OR staff that's here. So we did a nice study again, Robinson, Doug Overby, and some other previous residents here. Even John Moore is on there. This is a beautiful study. We went over and lit a bunch of fires. And we used alcohol-based and non-alcohol-based preps. And I don't think it's any surprise to anyone here that if there's no alcohol in your prep, plain chlorhexidine or iodine paint, you can't light a fire with it. Alcohol-based preps, you can light a fire 1 in 10, even 1 in 4 times. And these are not just little flash flames. These are light our entire specimen on fire. We have to put it out, start over. What about waiting? Manufacturers tell us 3 minutes or 60 minutes in hair-bearing areas. Is that effective? It's okay. It's not terrible, right? What about pooling? Pooling is the absolute worst. You create a pool like the umbilicus, and you can see there 95% of the time, we lit a fire. It's almost like you can't not light a fire. Wet prep or a pool, absolute worst for an alcohol-based prep. Whether it's chlorhexidine-based, ChloraPrep, or DuraPrep, doesn't matter. Don't just listen to me in my studies. This study came out this year from the military. Very similar findings. Their goal, you can read, if you read the study, it's called the IGNITE study, is very clearly trying to say we don't have to wait 3 minutes. And they kind of proved it. They showed that waiting 3 minutes was really unnecessary for most of your ChloraPreps, most of your DuraPreps, although some you had to wait, especially when there was hair. But their solution or final conclusions was you can't light a fire if the prep is dry. There's no pools and the prep is dry, all the fumes are gone. So a 3-minute wait time isn't perfect if there's a little pocket over here and there's still a pool of prep. So we have to be actively looking at the areas we prep. And if we put those drapes on and the drapes get soaked, that's a pool too. Other fuels, and this is something that has just recently came out, and I think it poses a significant risk because it's a little bit unique. So there's no sting barriers that happen to have a little bit of alcohol in them. All right, use them to assist dressings, wound vacs. Multiple fire repellents have been described, not just out in the world in private practice, but in the VA. I just got this email at the beginning of January. NSO's National Surgery Office. The concern with this in the operating room is usually everyone's done, right? You're all high-fiving. We did a great case. We're just putting on the drapes. Taking down the drapes, we're just putting on the wound vac. I'm gonna spray a little bit of this. Oh, it's oozing a little bit. Is that bovie still connected? Oh, it is. Okay. Boom, fire. We have to be critically aware until that patient is out of the operating room. Oftentimes, they're extubated by that point, right? And they're getting supplemental oxygen. Now it's an even higher risk situation, so we can't forget. The case is not over, the risk is not gone until we remove a leg of that fire triangle. You remove that energy device, you're not gonna light a fire. Fuel summary. In high-risk situations, head and neck especially, with an open oxygen source, if we use plain chlorhexidine in a low-risk patient, you're not gonna light a fire, unless you're intentionally in the airway. When you use alcohol-based preps, we must wait until it is dry. That may not be 3 minutes, maybe longer. Most times it's shorter. But we need to make sure that it is dry and there are no pools. And then the other thing is we need to use caution when we think the case is over. All right? Do not assume that the risk is gone, specifically with this no sting barrier. Okay. Spent a lot of time talking about what we can do to prevent OR fires. Another key part of this is the fire risk assessment, which a lot of our surgeons may not have seen, but should be getting done in all the procedures here. It's a 5-point scale, 3 to 5 puts you in a high-risk situation. And you can see it's really based around the fire triangle again, right? Alcohol-based prep. We got a fuel. Is this procedure near the airway, above the xiphoid? There's our oxidizer, or you're asking obvious questions about oxygen or nitrous oxide. And here, ESU laser or fiber optic. This reads straight from the data. If we're in a high-risk situation of 3 to 5 points, and you hear that in your surgical timeout, we should pause and be like, is there anything we can do to reduce our risk? Maybe we change the prep. Maybe I decide to use a bipolar device, which is much less likely to create a spark. Can I talk to anesthesia and turn down oxygen to room air content, at least during that time when I need to use the energy? We got to think about these things. And then don't forget Cavalon at the end of the procedure. Fire risk assessment should be happening everywhere. As I mentioned, I've been on a legal case for a fire that happened in cardiology. I've been involved in one that happened in interventional radiology. I've read about ones in GI. So it's not just the operating room, but it's anywhere that we have all the pieces of the fire triangle, usually if you're going to use an energy device. And I'm emphasizing the importance of paying attention to the fire risk assessment. I am also at fault of kind of letting the timeout just kind of pass in and out of my brain. But I do think, given the critical importance of this and the high risk for a severe disabling injury, that we need to start listening when that pops up again. And don't just say fire risk assessment completed. Like, listen to the number, 3, 4, or 5. We got to start thinking. And maybe there's nothing you can do other than be aware of it, and that might be enough. But if there's something you can do, we should. Okay, what to do with an OR fire? I think this is relatively obvious. It doesn't happen in this situation. This is from that anesthesia patient safety video. But the first step is to stop the flow of airway gases. This is why I started with oxygen. If you have supplemental oxygen continuing to be supplied to the field, it's going to be very hard to stop that fire. Not only that, the fire is going to track into the airway. Most of the deaths that occur related to OR fires are because of airway injury. Oh, I did put a picture in there. There it is. Doesn't that look terrible? You're not surviving that. If an airway fire does occur, pull the tube, pour in saline. I remember when I first read this and I was like, that sounds terrible. I'm going to drown this person. They're going to die because of what I'm doing. The reality is, if they have fire inside their lungs, that's killing them. And we got to stop it right now. And think about how long anesthesia will hold the gases as they're trying to put in the endotracheal tube. This event lasts 5 seconds, maybe. Probably seems like an hour, but it's very quick. Anesthesia will try to intubate 30 seconds, a minute, sometimes longer, and the patient survives. So having them hold their breath, in a sense, while you put out the fire in their lungs, is critically important and must be done. After we do that, we're going to pull everything off the patient, put it on the ground, and stamp it out or pat it out. Keep that material, because unfortunately, now you're part of a sentinel event, and all of this is going to have to be reported. And then finally, get back to it. This, in practice, happens in 30 seconds, all of it. How do I know? I was fortunate to go to India where they let us light a bunch of fires. Now I put this one up there just to emphasize how hard it is to see an alcohol-based fire. If you didn't see that first little spark gap, a little bit of yellow, you might not even notice, right? They're so hard to see. This is why prevention is so important. How hard are they to put out? Not hard at all. Done. That's it. Right? Put the fire out, swipe it all off on the floor. Are we okay? Head and neck's a little different, right? Now you're up near the airway. Problems can be happening. But this can all be addressed in 30 seconds. So this is not where we got to be focusing. This is really the point of this. When a fire happens, you guys are all smart, you're well-trained, you'll take care of it, and it'll be easy. It's preventing it from happening that's critical. There's only been 2 known cases where they've had to do the RACE thing, which is on all the training, but is rarely ever used. So rescue, alert staff, confine that room, shut off the gases, electrical power, and evacuate. One of these was related to a device malfunction that then started a fire near the anesthesia machine, and it kind of got out of control. I don't know the other one. But this is very unlikely. I put it up there just to be complete. Should you have a truly disastrous fire, a real fire in the OR, put it out if you can, get the patient out of the room, alert the staff, and so on. Okay. Interestingly, Joint Commission has just put out some new guidelines that really line up with what we're doing. Sentinel Alert number 68. It's only about a year and a half old. And if we look at the website, they say, we need these things. Why do we need these things? Because there's a lack of shared understanding and communication. That's why this event is so critically important with all of our OR staff and our surgeons together. An insufficient timeout to assess the fire risk. We talked about that too, right? Don't let the fire risk thing just go in and out of your ear. Just pay attention to it. If it's a 1, okay, no big deal. If it's a 5, could be a big deal. Let's think about it. A lack of competency to understand risks. We are doing here the SAGE's hospital compliance modules, which is awesome. So we're doing extra training. We're doing extra training today. Overconfidence and risky behavior. You know, we have to think about the critical importance of this. A single fire event not only devastates the patient, it devastates the surgeon or whoever's doing the procedure, cardiologist, neurosurgeon, whatever it may be, and it devastates the hospital system because the entire hospital system is going to change. And beyond that, there's medical legal risk and everything else. It's not worth ignoring this. Equipment malfunction or failure is not a lot we can do about that. A lack of training, and we're working on that right now. So if you look at their steps, it goes right along with the problems they listed, right? Ensure you got a robust FRA. We do here. We just got to pay attention to it. Maintain local oxygen concentration at 30% or less when possible. I think this is something we got to kind of poke our anesthesia colleagues. It's very easy to kind of just dial that oxygen up and let them run at 100% SpO2 the whole time. But can we dial it down just a little bit? Can we get it a little bit lower just to reduce our risk? We got to think about the devices we're using and how we're draping. Providing training. Of course, you should report fires. And this is what I really loved at the end of this, and we didn't pay Joint Commission, but they said encourage education. And not only that, they named us. They named SAGES and FUSE, which again, it was the FUSE group, Tom Robinson, and I helped a little bit, who got the hospital compliance modules here that you guys all had to complete. That's outstanding. If you want to go one step beyond, you can get FUSE certified yourself and really understand how energy devices work and what are the risks. All right, back to the main point, critical point. We need to focus on prevention. We start with our risk assessment, and then we break it down by pieces of the fire triangle. Focus on the oxidizer, we go to the heat source, avoiding sparks or spark gaps in high-risk situations. We think about our fuels, 100% avoiding wet prep or pools. And then don't forget, the case isn't over till it's over. All right, let's not get caught patting ourselves on the back that we reduced our fire risk. We leave the room and our residents are there putting on the drape and they're like, I gotta stop that bleeding. The case isn't over till it's over. All right, only you can prevent surgical fires. I think that's it. Sir.
Thanks very much, Dr. Jones, for giving grand rounds, and thank you to everybody who's attended this morning. It's a good way for us to get together and talk about a common issue that we all have to work on. Dr. Schuler.
Dr. Jones, thank you very much. My question is, why do we use alcohol-based preps? Are there data to show that they prevent infection better than non-alcohol-based preps? I mean, one obvious thing is get rid of the alcohol.
Unfortunately, yes, there is good data. So in 2017, CDC guidelines came out and said, for the vast majority of procedures, we should use an alcohol-based prep. They didn't specify ChloraPrep, DuraPrep, or what have you. And they cited a lower risk of surgical site infections. And so, yes, there is data. So as you're considering using a non-alcohol-based prep, we need to consider that fire risk. So again, head and neck, open airway, there's a low risk of infection in most of our head and neck procedures, right? Maybe we should consider using plain chlorhexidine.
Thank you.
Anybody have a question or want to make a comment? Dr. Robinson?
So thank you, Dr. Jones. That was an excellent review. I have two questions. First, and I'm sorry to the residents that I'm a few days late for the abscess, but one of the classic abscess questions is somebody's under general intratracheal anesthesia and you have an airway fire. What is the first thing you do? So could you tell us what the first thing you do is for an airway fire under general anesthesia? And my second question is just like, I think one of the most powerful concepts you got across was if we can remove one piece of the fire triangle, we can prevent fires. And Doug and I here were talking during the thing that, right, if you use the Cavalon, well, maybe we should take away the Bovie tip and then you can't have the ignition source. Do you have any pearls or like high risk scenarios that you could share with the group so we can prevent, you know, we learned about pooling in the belly button and the umbilicus and stuff. Anything like that. So airway fire, what's the first thing you do? And then any like good scenarios that we could avoid?
Sure. Airway fire, disconnect the breathing circuit. You're getting rid of the oxygen. You're either disconnect or removing the endotracheal tube. It depends on how the question is stemmed, but it all revolves around disconnecting it or removing it. Typically, it's a disconnect and then you're pouring saline in the airway and then you're removing it. So that should be the answer, hopefully all of you selected. With regard to high-risk scenarios, it comes back to location. The challenge with the head and neck region oftentimes is you're rotating the head and you're creating pockets, right, with your drapes. So a lot of us like to stuff a blue towel behind the neck just to kind of create that gap and give a little boost almost to the drape that we're going to drop down there. That's a perfect place for all that ChloraPrep to pool up and create a nice little pocket. Not only that, if it's under the drape, now it's collecting with the anesthesia, the oxygen underneath that area. So draping is critically important. So as we think about draping, we need to think about not only where is our prep going to go, is it going to create a hidden pool, but we also have to think about how it may be trapping the oxygen and changing items that are not normally flammable into things that are now flammable. So even if the pool is not there, but we've created a local oxygen concentration of 30% or greater, doesn't matter. Now I can light my gown on fire. Now I can light the drape on fire. And that's why I really want to emphasize the oxygen content, because depending on how you drape, if you do some crazy box like I showed up there, and I mean, I can't even imagine what's going on. You get a spark anywhere near there, all those drapes are up in flames. And so I think really paying attention to draping and avoiding pools are the two critical items, and it can happen anywhere, groin creases, anywhere.
Dab it with the towel to prevent the pooling, or would that kind of take away from the like
Antiseptic, yeah.
antiseptic?
The manufacturer does not recommend doing that. You got to let it dry.
Yeah.
And minimum, in theory, 3 minutes. We just know that that's not 100% protective, and it's supposed to be 60 minutes in hair-bearing areas, which I admit I've never really seen. One thing I will mention really quick, that IGNITE study that I put up there, they did find a significant difference between DuraPrep, which is a little bit more tacky or sticky, and ChloraPrep. So ChloraPrep will evaporate more quickly, whereas that DuraPrep, they were able to light fires up to 3 minutes out. So if you like DuraPrep for whatever reason, really, really pay attention. Make sure that is dry before you get started. Good question. Other questions? One sec.
Regarding
it does have alcohol. I don't know that, I haven't tested it, so I don't know if it lights fires at the same time, but I would see no reason to expect it wouldn't. Sorry, in the back?
regarding the installation of saline into the airway, how much is like recommended, and then what sort of effects can we expect on the respiratory system after that? How does that affect free intubation? Are they going to need a bronch shortly thereafter? What sorts of things do we do after that?
Yeah, can you repeat it? I'm sorry, just a little bit louder. I can't.
I was asking in terms of when you instill the saline into the airway.
Yeah.
How much is recommended, and then are they gonna need a bronch thereafter? What sorts of effects can we expect to see in the aftercare once that has been done?
I've never had that question. It's probably not very much. I wonder if our thoracic colleagues would have an idea. You know, if you have a fire in the airway, you just pour some fluid down there. It's probably not that much. Yeah, some kind of guess. Yeah, so Dr. Mitchell is saying that the fluid gets reabsorbed very quickly, and the priority is putting out the fire. So don't worry too much about the volume. And then bronch is coming soon after that too. But the critical event is putting out the fire. So put some down there until you're confident that your fire is out. Yes.
But a lot of the data focus on the treatment, but truthfully, I mean, it's very great. Before there, then, and when the first spark comes, there's another, 5-6 minutes. By the time you put all the drapes on and, pass all the cords and stuff, how meaningful is that? Probably the real time to first ignition is going to be 8 or 9 minutes. If you,
Yeah.
How much that does reduce that fire risk?
So the 3-minute time is supposed to be before draping, because if the solution is still wet, then it gets into the drapes. So that's why you're supposed to wait the 3 minutes before you drape. If you drape beforehand, you have a higher risk of it getting inside the drapes themselves. Then you're exactly right. Once the drape is on, there's going to be some amount of time before you make that first incision. However, if you have a pool of solution, just think about the belly button again. For some reason, you weren't paying attention to that. The fumes are still there. And when we were doing our testing, I think we waited, I want to say double. We just got really bored, so we didn't go longer than that. I think 6 minutes. And there was these little pools. We tried to make a 1 by 1 centimeter pool to mimic a small umbilicus. And the pool was still there. We could still light fires. So 3 minutes before the drape should, not 100% guarantee, but near guarantee without any pools that the solution is dry.
I think one topic that you could touch on is you brought up team and each person's role in all of this, and that makes me immediately think of the cultural issues in the application of safety bundles in the operating room. So we got to pause and not just let the risk assessment go by quickly, but here at the university hospital, we use the I need clarity phrase when a member of the team is not fully understanding the process that we're following right now. They need some clarification that any member of the team should be able to pause what is happening in order to fully explain every step of this process. And so I think you mentioned in the Joint Commission checklist there that communication was one of the key aspects. Have you seen any in your experience with your review of cases? Have you seen issues that are related to that that you maybe make us aware of?
Yes, so there's a cardiology case I reviewed, and it's like the Swiss cheese model. All these things came together. As I read about the case, it was clear that there was a rush. There wasn't enough staff. The provider themselves prepped, which was not their standard approach, and then immediately got in there, draped themselves, started the case, and then there was a fire. And so a lot of our system design is based around everybody doing their part and everyone being able to speak up. At the VA, we call it stop the line. Anyone can stop the line at any point if they're uncomfortable. And I think this is a place where we need to really encourage people to stop the line. We do that FRA and it's a 5. Someone should be raising their hand and just say, hey, is there anything we can do to reduce the risk? Simply doing that raises awareness and may prevent a disaster. You may not be able to do anything, but it shows that you're all thinking about it, you're all on the same page. And now we know that our OR nurses, our techs, the surgeons, the residents, anesthesia, everyone in the room is like, oh yeah, that's right. This is a high-risk situation. Maybe I'll try to turn down the oxygen on my own. And we can all do all of our pieces. So communication is a critical part of it. We should all feel empowered to stop the line or ask for clarity at any point. And I think that FRA in the beginning is the obvious first step to do that.